Good morning, everyone. Welcome to the COVID-19 Community of Practice for Ontario Family Physicians. My name is Ali Damji, and I'm a family doc and division head of primary care at Trillium Health Partners in Mississauga. Really pleased to have everyone here today for our session on vaccine-preventable diseases and e-consults. So a mix of both some clinical aspects as well as some ways to better optimize your practice in response to the feedback that we've heard today. We have a really great panel of speakers today and really excited to share their knowledge with you today. I'd also like to thank both the DFCM and the Ontario College of Family Physicians for continuing to allow us to provide these sessions on a regular basis to physicians across Ontario. I'll turn things next to Dr. Mekalai Kumanan from the OCFP to lead this next part.
Thanks, Ali. Good morning, everyone. Really nice to have you all here with us today. And I'd like to just take a moment to thank our panelists. I'm really looking forward to today's session. Just a quick reminder, this is a Main Pro accredited session, and you'll receive more details afterwards. Next slide. So just moving on to our land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite us all to reflect on the territories we are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from Kitchener, the lands traditionally used by the Haudenosaunee, the Anishinaabe, and the Chinantan. Next slide.
Thanks so much, Mekalai. So today I was going to provide the reflection for starting off today's talk, and this is particularly topical, as many of you know. This weekend there's going to be the coronation for King Charles in the UK, and as part of that, he's meeting with Indigenous leaders, and this is the first time in history that that's happened in terms of the monarchy in the UK meeting with Indigenous leaders from the respective areas that were colonized. And so there's been a lot of commentary on how this is very historical and this is an opportunity for reconciliation and being able to acknowledge that the leaders of the Indigenous nations are truly leaders, and that that leadership opportunity for them to lead these countries was taken from them. And the reason why I wanted to bring this up is that not only is it very topical, but I think it prompts for me some reflection on, in all of our systems, we often talk about how the healthcare systems, the educational systems that we all work in do have aspects of colonialism embedded within them. There are systemic factors that are embedded and baked into our systems that disenfranchise people. And so, I think similarly to the steps being taken here, I think we should also be thinking about how do we take those steps in our respective organizations, and how do we do that difficult work of reaching out and acknowledging the baggage that we carry, and being able to have respectful conversations and open conversations with Indigenous leaders and create the opportunities for them to be able to lead in our systems moving forward in the way that they want to lead. So that's just a little bit of a reflection to kick things off today, and appreciate the opportunity to do so. Next slide. In terms of the community of practice, for those of you who haven't been here before, these are Main Pro accredited sessions. The sessions are recorded as well, and the resources that are shared today will be available on our website and will be emailed to all the participants as well. I also want to briefly take a moment to thank the planning committee for their hard work in organizing all of these sessions, both in the past and for today's session as well. Next slide. As I said before, we have a wonderful group of panelists that are joining us today, and really pleased to have them with us. We have panelists that are going to be speaking to vaccines and different vaccine-preventable illnesses. And then we also have leaders for e-consult services and the e-health services in our region as well. So really thrilled to have that. Next slide. So now I'll turn things over to each panelist individually to introduce themselves and speak briefly to their disclosures, starting with Dr. Sarah Wilson.
Good morning, everyone. Thanks for the opportunity to be here. My name is Sarah Wilson. I'm a public health physician and I work at Public Health Ontario. I'm an employee of PHO. I work in the area of immunization and vaccine preventable diseases. In terms of my other disclosures, I'll just first mention that I have no relationships with industry or vaccine manufacturers. But in terms of my relationships with nonprofit organizations, I have received or I have participated as a co-investigator on some COVID-related vaccine work funded by the Public Health Agency of Canada, and I'm a member of NACI. Thank you.
Thanks so much. We'll next go over to Dr. Daniel Warshafsky.
Hi, morning, everybody. Daniel Warshafsky. I'm an Associate Chief Medical Officer of Health with the Ministry of Health, and I don't have anything to declare.
Thank you very much. Over to you, Dr. Crabtree.
Hi, Marilyn Crabtree. I'm a family physician and the clinical lead at the Great River OHT. That's my primary role now. And I have had various relationships with digital health programs. I'm on several OMA committees as are listed here. I'm also, most importantly, the primary care lead for Ontario eServices and also for Access MHA.
Great, thank you so much. For myself, the one to disclose here is just that I receive honoraria from the Ontario College of Family Physicians. And over to you, Mekalai.
Thank you. Hi, everyone. I'm a family doc in Cambridge, and I serve both as the president of the OCFP and the chief of family medicine at the Cambridge Memorial Hospital, neither of which poses a conflict for today.
Thanks so much. Next slide. So in terms of how to participate in today's session, please keep in mind that the Q&A function is there on the bottom of your screen, and I already see some people are posting questions, which is excellent. So please continue to do so. And before you put a question into the Q&A, make sure to take a look through the list. And if there's a question that's already been asked that's similar to what you wanted to ask, feel free to upvote that question because that will bring it to the top of the list and then be able to be flagged for my attention. For the chat box, you can also use that as well. But please, if you have a question, put that into the Q&A. It makes it much easier for us to track the questions if you put questions in the Q&A and use the chat more so to share your reactions and for networking. Next slide. All right. And again, thank you to our panelists. Looking forward to our session. And we're going to kick things off with the vaccine preventable illnesses talk. So over to you, Dr. Wilson.
Okay, great. Well, thanks again for the opportunity to be here. So today I'm going to be covering some hot topics in vaccine preventable diseases, focusing primarily on measles and pertussis. But I was also asked specifically to review some of NACI's recent guidance on invasive pneumococcal disease, specifically, I'm losing my voice already, some pneumococcal vaccine recommendations released in February. Next slide, please. So first we're going to start with measles. And if you go to the next slide, please. So this next slide is just a few screenshots of what's been in the recent media. I think everyone's aware that measles continues to be in the foreground. We have on the right-hand side a press release from Toronto Public Health released last week describing a lab-confirmed case of measles that had a number of healthcare-related exposures. And on the left, a report from the WHO describing increased measles activity in Europe. And we're seeing increased measles activity in all regions of the world, but I thought I'd emphasize Europe. It's a place that people commonly visit in the summer, and it's a place that that many people don't think of when they think of measles risk in terms of possible exposures. You can go to the next slide, please. So this is a figure that represents the numbers of measles cases we tend to see over, every year in Ontario. This is looking back to 2013. And you can see there's a lot of variation year to year, and the variation is driven largely by variation in global measles activity. And of course, we see that there was essentially no cases over the pandemic. We did have one in an unimmunized 11-month-old infant in 2022. So far in 2023, there have been, at least as of earlier this week, I reviewed this data as of May 1st, 5 measles cases in Canada, of which 4 out of those 5 were in Ontario. And unfortunately, given our large population size, we do tend to have, relative to other provinces and territories, a fair number of measles importations every year. And the countries of travel are listed on this slide. This is all in the public domain. This is reported by the Public Health Agency of Canada, but really important to reflect on the risk of measles in terms of travel abroad. And if you can go to the next slide, please. The next slide is just a reminder of some of the recommendations for measles vaccination before travel. These are taken from a global measles advisory alert from the Public Health Agency of Canada, and it summarizes vaccination recommendations from NACI in the Canadian Immunization Guide, and these recommendations are also included in the Ontario publicly funded schedule. So there is good alignment for these recommendations across these different documents, and these doses are all publicly funded in Ontario. So the recommendations, if you can go back still on this, thank you so much. I just wanted to highlight that for adults born before 1970, so these would be people age 53 and older, that people are recommended to have 1 dose of measles vaccine. Our recommendation is that people should be offered vaccine rather than to have serology. It allows them to be vaccinated at the time that you're having the discussion. And then for everyone else, with the exception of infants, which I'll get to in a moment, the recommendation is to have 2 doses of measles before travel. So this isn't 2 additional doses of measles, 2 doses total. And this is really important, I would say, just to emphasize a few groups. For example, children who are 3, who are not yet due for their 2nd dose of measles containing vaccine, that would be a good population to ensure they get that dose before travel, as well as maybe some older adults who would have only received 1 dose as part of the routine schedule in place. So really emphasizing the message of 2 doses for travel. And then finally, the last group there, infants 6 months to just under 1 year of age. This is a group that can receive an early dose of MMR as early as 6 months. And we strongly recommend this before travel to measles endemic countries. It's really important and provides them with protection. And I think the key piece here to emphasize is that if infants do receive this early dose, they do need an additional 2 doses. So 2 doses on or after the 1st birthday to be considered up to date for future measles protection moving forward. Okay, thank you. If you go to the next slide, please. So the next slide is just a reminder that if you do see a febrile rash illness in a returning traveler, if you're wondering about measles, this is a reminder to please consider ordering specimens beyond serology. It's really important to collect specimens for measles PCR testing to diagnose measles infections. So there's some additional detail there in the table just to highlight that the specimens are either an MP swab or a throat swab or urine. The dates in terms of in relation to rash onset are included in the table. And please, if you are considering measles, if you are ordering these tests, please do call your local public health unit to say that you have a suspect case of measles, that you're ordering these specimens. They can provide advice to the client, as well as, start making some preparations so that if the measles test is positive, they can immediately launch into the contact follow-up that occupies a lot of public health time when we do identify measles cases in Ontario. Okay, next slide, please. Okay, so then moving into pertussis, if you can advance the slide, please. Here are also some clips in terms of recent news stories and what's been in the media. We have been seeing an increase in pertussis circulation in Ontario, in particular in the southwestern part of the province. And so there's been a lot of important attention about pertussis circulation. If you could go to the next slide, please. So I thought then it would be a good opportunity just to highlight and remind everyone of some of the key measles vaccine recommendations. So one is the recommendations relating to Tdap vaccine in pregnancy. So this has been recommended by NACI since 2018. Unfortunately, Ontario has the somewhat dubious distinction of being the last province in Canada to publicly fund this program. This was announced last spring in 2022, but I'm sure you're all familiar with the NACI recommendation for a dose of Tdap vaccine in every pregnancy, ideally between 27 and 32 weeks. And there are many data, especially from countries that have very long-lasting maternal Tdap programs, demonstrating the effectiveness of these programs in reducing the risk to infants in terms of risk of pertussis infection and pertussis deaths in this age group, and lots of data to support the safety both for mom and baby. And then the other piece I wanted to highlight is that with pertussis circulating, this really is an opportunity to ensure that infants, children, adolescents are up to date in terms of their pertussis containing vaccines. On the far right, you can see the schedule. I think all of us know there are many, many doses of pertussis containing vaccines. And due to the impacts of the pandemic, there is, I think, a reasonable possibility that some of these age groups, especially children who would have been due for their preschool booster at 4 to 6 or adolescent booster, that they may have slipped through the cracks. And so the pertussis circulation we're seeing now is really an opportunity to remind ourselves of the importance of ensuring these immunizations are up to date. Okay, next slide, please. So now we're going to move into invasive pneumococcal disease. I have the screenshot of the cover of the NACI guidance. This was released in February, and I'm going to just provide a high-level overview. This is a very long statement, and I wanted to emphasize, you can see in the green text that the framing of the statement is that it's public health level recommendation. So I do think this is important to note that the framing of this statement, there's detailed cost effectiveness analyses presented. The target audience of this statement is really for people like Daniel and colleagues to make recommendations, to make program changes in the provinces and territories. But I do think the detailed evidence that's reviewed in the statement, as well as the NACI's recommendations, are still relevant for counseling individual clients and patients. Okay, so if we can go to the next slide. So the next slide is just a reminder of what these new pneumococcal vaccine products are. So there is a relatively newly authorized PCV 15, so covering 15 serotypes of pneumococcus, vaccine that's been authorized by Health Canada for both children and adults, called Vaxneubance. And then we have PCV 20, so covering 20 serotypes, and this product is Prevnar 20. And so far it's been authorized for adults, but we do know that a pediatric authorization is coming soon. So although we're talking about adult immunization today, certainly expect that we'll be having more conversations about potential changes to pediatric programs in the future. The bottom of the slide is a figure that just represents the different products, different vaccine products, and looks at the number of serotypes that are included in the vaccine. And you can see that with these additional vaccines, there's additional serotypes. And the bottom row there, which I haven't yet discussed, is the polysaccharide vaccine, Pneumovax 23, which you can see covers 23 serotypes. Okay, so we'll move to the next slide. So this is a slide, it's a little bit busy, but just to orient you, so this is looking at invasive pneumococcal disease isolates. So pneumococcus found in the CSF or the blood in Ontario adults who are over 65. And then our lab colleagues have looked at the serotypes for these isolates. And so what's represented in light blue, orange, and gray are serotypes that are covered in the PCV 20 vaccine. And so you can see over this 11-year time period, if you focus on those colors, that anywhere between 40 to 50% of invasive pneumococcal disease isolates are caused by serotypes that are in the PCV 20 vaccine. And so this is provides us with some insights into the potential impact that a PCV 20 vaccine could have, in particular for this age group that we know is at particularly high incidence and high risk of IPD. So potentially really quite dramatic impacts possibly if this program were to be implemented. And then we'll move to the next slide. So the next slide is the recommendations from the NACI statement. So I'm just going to orient you a little bit. I know there's a lot of text here, and the text is really highlighting risk groups at increased risk for IPD. So NACI's recommendation is that PCV 20 or Prevnar 20 should be offered to a number of different adult age groups if they've not been previously immunized against pneumococcus. And so this includes all adults, so everyone 18 plus who are immunocompromised, and the immunocompromised conditions are listed there in purple. It's also recommended for adults 50 to 64 if they are either immunocompromised, so same list as purple, as what's in the purple panel, as well as other risk factors, things like cardiac disease, renal disease, lung disease, etc., as well as people who have other risk factors. And NACI's recommended several of these risk factors, things like use of unregulated drugs, alcohol use disorders, people who are underhoused for some time since 2008. And so this is also being emphasized in this statement as well. So these are the groups: immunocompromised conditions, chronic conditions, as well as these additional risk factors for people who are 50 to 64 years of age. And then what's represented on the far right in orange is the most, I would say, sort of straightforward of the recommendations. Everyone over 65 should be offered PCV20. Again, this is a recommendation that's really pointed to public health decision makers. NACI also noted that PCV15 may be offered, but if PCV15 is offered, it should be followed by PPV23. And so although this table is quite complex in terms of the conditions, one thing I do want to emphasize is that if provinces do implement PCV20, it does actually have an opportunity to really simplify the program. It would be one vaccine offered to a number of different risk groups. We wouldn't have to worry about who receives PPV23 afterwards. There'd be no recommendations, at least at the present time, for boosters. So I think it would certainly have the advantage of simplifying vaccine recommendations. But we'll see where the program goes, since the statement is relatively recently. Okay, and then we're going to move to the last slide. And the last slide is NACI's recommendations for PCV20 in people who have previously been immunized with a pneumococcal vaccine. So it's very straightforward. If someone has never been immunized with a pneumococcal vaccine, they would be offered PCV20. But if people have received Pneumovax 23 or Prevnar 13 with Pneumovax 23, the recommendation would be to offer PCV20 after 5 years from the last dose. If someone's received Prevnar 13 only, then the recommendation would be to offer PCV20 at a shorter period, just one year after that dose of Prevnar 13. And then if you can go to the next slide, it's just a short acknowledgement slide thanking my colleagues who I work with at PHO who provided some helpful comments and feedback on this deck. And I'll turn it back to Ali. Thank you. Looking forward to the Q&A.
Great. Thank you so much, Sarah. That was such a wonderful overview of all the different vaccine-preventable illnesses and lots of activity in the Q&A. Before we head to the Q&A, though, I would like to call Daniel to present a few slides on the COVID boosters. We actually got quite a few questions about that already. So for those of you who posed those questions, please feel free to listen in carefully as Daniel gives us that update. Thank you.
Great. Thanks, Ali. Yeah, you can never get away from COVID still, despite my best trying to do so. But can we go to the next slide, please? So just a quick update for everybody in terms of the still relatively recent spring booster campaign updated guidance and what things mean. So I thought just as a quick summary, this slide might be helpful of what we're really talking about when we mean up to date. So as of April, that's just when we put the updated guidance available. So any child or infant 6 months to 4 years, up to date is a completed primary series. There are no booster doses recommended in that age group as of yet. For anyone 5 years and older, being up to date is completing the primary series and at least one booster sometime since September 1st. Ideally within the last 6 months, depending on how high risk the individual is. So as you see the next point there, specific high risk populations, it's completion of the primary series and a booster within the last 6 months. So it does depend on the level of risk for each individual, but that's the definition we have right now of what's considered up to date. We do know NACI is going to be commenting on potential need for fall boosters for all of these populations, hopefully soon, probably in the next couple months. And so things are going to change in the summer when we do have that guidance from NACI. But at this time, this is what's considered a complete up-to-date series for COVID-19 vaccines. Next slide, please. And just to quickly, sorry, this is a really busy slide, but just to quickly really run through what the populations that have been recommended an additional booster in that high-risk group are. And so that's any individual over 65 years of age, any resident in a congregate setting that's primarily elderly individuals like long-term care home, retirement home, elder care lodges, anyone 18 and over living in a congregate setting with complex medical needs, any pregnant individual, anyone over 18 who's moderately to severely immunocompromised, and that's the definition of what exactly that means is within the guidance that we have posted as well. And then any individual 55 years of age or older who identifies as First Nations, Inuit, Métis, and their non-Indigenous household members. And so just to be clear, the recommended dose interval for the vaccine is still 6 months. That's the best evidence for having the best possible and most robust response to the vaccine. For certain individuals that are especially high risk, we do know, for some of the transplant patients, for example, the minimum interval that can be used is the product monograph, which is, depending on the product, either 3 and 4 months. That would be the minimum acceptable. So there may be certain circumstances where an exceptionally high risk patient might need to have a shorter than 6-month interval, but broadly for all of these high risk groups, 6 months is still recommended. I think that's the last slide I had.
Great, thank you so much. So what we'll do is we'll stop sharing the slides and then we can go to the Q&A, and quite a few questions there. So I'm going to start with one of the most upvoted questions here, and I'll field this one to Dan. So could you please discuss masking? Many colleagues have dropped the mask mandate for patients in the office. Also, what about when we were in large group settings? Previously, masking in this environment was still recommended. Is that still in place?
Yeah, that's a really good question. So right now we're having quite low overall community rates of COVID-19, and Sarah probably knows the epi better than I do if she wants to comment afterwards in terms of what we're seeing. So broad recommendations for COVID-19 masking aren't currently out, partly because we're having low rates of COVID, but also partly because our community level of immunity is exceptionally high. Given the multiple waves of COVID-19 we have, the excellent vaccine uptick that we have in Ontario with primary series and then booster doses, particularly for high-risk individuals, the level of concern for COVID-19 infection has come down significantly since the heady days mid-pandemic. So broad masking recommendations aren't recommended in the community at this point. Within a clinic, I think it really is incumbent to look at what your patient population is and what's coming in to be seen. So for example, like I work at Toronto Rehab, we still mask for everybody. There's exceptionally high risk patients coming into Toronto Rehab all of the time based on the nature of the facility. If you have, though, an outpatient sports medicine clinic, for example, which I also have, where it's primarily younger individuals who don't have chronic conditions, then requiring masking of your patients and for yourself may not be something that is necessary to do. So there is a little bit of risk assessment based on the clinic, based on the types of patients you're seeing, and of course based on your own personal risk factors, what would be recommended. So broad recommendations, no, not at this time. Again, we'll see what's happening in the fall. We know that in Australia right now we are seeing a pretty significant respiratory season surging right now. But at this point, it's really a risk assessment based on the type of practice that you have. But Sarah, I don't know if you want to comment anything about the epi we're seeing now, or you don't have to.
I don't think I have anything further. Thanks, Dan.
All right, thanks for that. I think it's helpful to appreciate that there's that nuance, as you're saying, and it's almost that context both for yourself and for your patient population. So I think that's helpful for people to kind of factor that in. I'm curious, are there any tools or risk calculators? I know in the past there used to be those types of things of what was sort of low risk, medium risk, or high risk. Is there anything like that available at this stage?
So there's nothing coming out kind of centrally right now in terms of define that level of risk. Actually, I don't think PHO is doing it anymore, but again, Sarah would know better. But again, looking at the definitions right now in terms of just community levels of risk, it would be something hyper-local at this point if we are seeing a little surge, because broadly across the province, we aren't seeing big changes in the epi at this point in time. Again, when it comes to the fall and when respiratory season expect changes, we're going to have more advice coming out about that centrally, but right now there isn't a specific local or regional risk tool that you can use to determine.
Great, thank you so much. Our next question here is for Sarah. Can you comment on when it's appropriate to test for pertussis in the community? I often find it is not that clinically useful as it takes weeks for the results to come back, but sometimes it's hard to differentiate from croup.
Yeah, I think that's a really, really great question. I think that it is certainly challenging. I mean, I think for me, my main message here was that we are seeing more pertussis, to make sure that people are thinking about pertussis in the differential. I mean, normally we would say think about it for prolonged cough illness, but when we're seeing so much activity in the Southwest, I think we want to do more than just swabbing after prolonged activity. So I don't know if I have much guidance beyond just ensuring that it's on you know, sort of on the differential, and if it's in the community, I think that you know, sort of that might then trigger you to think about swabbing maybe more likely than you might otherwise. And I think there's probably also factors related to, you know, are there young infants in the, or pregnant mom in the household? Like, are there other sort of family characteristics that might make you be more, you know, wanting to swab to really make sure that, you know, if you do identify pertussis, you know, that chemoprophylaxis can be provided. That's what public health provides to high-risk contacts, which include infants and as well as pregnant women. So that might also be a consideration in terms of, you know, thinking about family and other characteristics about really being thinking about who would be swabbed.
Great, thank you for that. And actually that dovetails really nicely with another question. So I might jump to that one, which is, you know, we're seeing a lot of non-pregnant parents and grandparents who want an additional Tdap vaccine. And this colleague's noting that sometimes OBGYNs may be recommending that the family members also get vaccinated. Has there actually been an updated guideline on this or recommendations for this for the non-pregnant members of the household?
I'm not aware of any updated guidance. I know that that there have been various studies and recommendations of this sort of cocooning strategy that's being described. But I think the research in this area is that it's been very challenging to implement that sort of recommendation for a lot of logistical barriers outside of just public funding. And so I think that in large part drove many of the guidance documents, plus other considerations in terms of protection to the individual fetus through antibodies transferring through the placenta for maternal Tdap programs. But Ontario's policy, and I'll look to Daniel to make sure that he can confirm if I'm reflecting this accurately. I mean, it's a one-time adult booster. It's not specific to a certain age. This is separate from the pregnancy recommendation. So if there is a grandparent or other adult members in the household with a, you know, a newborn infant on its way, that you know, that dose is publicly funded. You know, if they haven't yet received their adult dose of Tdap, I think the challenge is, you know, if there's other babies that come in the next few years, I think strictly speaking, those additional doses aren't publicly funded, but if they haven't yet received their dose of Tdap, grandparents and other adult family members in the household could use that as an opportunity to take advantage of that program. I don't know, Daniel, if you have anything to add to that.
No, you nailed it.
Thank you. So next question's pertaining a bit more to the pneumococcal disease and the vaccination. So first question is, why is PCV20 being promoted over PCV23? Would you be able to review that again?
Sure. So I mean, first of all, maybe let me just clarify that my intention is not to promote a particular vaccine. These PCV20 right now is not publicly funded. And so my goal here was to review the NACI recommendations. So I certainly don't want there to be any misinterpretation of sort of promoting a particular vaccine that currently would require private purchase. So that NACI statement is for public health decision makers, people like Daniel and his colleagues who are making decisions about programs. So from that vantage point of thinking about publicly funded programs, PCV20 does have a number of advantages over the current sort of paradigm of pneumococcal vaccine programs. It would involve only one dose. So for example, just by way of very specific example for immunocompromised people, right now the NACI guidance is for PCV13 followed by PPV23 and then another booster dose of PPV23 in 5 years. If PCV20 were implemented in publicly funded programs for immunocompromised people, the recommendation would be for PCV20, full stop. It wouldn't require additional doses. And right now there would, I mean, you know, I don't want to say make conclusions about, you know, 20 or 25 years from now in terms of booster dose recommendations, but right now there's no recommendations for booster doses of PCV13 for high risk adults. So, you know, there would only be that one dose of PCV20. So it does certainly have some advantages of simplifying schedules. And the NACI statement for older adults 65 plus, so moving away from the immunocompromised discussion, there is a lot of detail in the NACI statement reviewing the cost effectiveness and the fact that conjugate vaccines tend to be more immunogenic, they tend to last longer. And so that is the additional benefit that PCV20 is likely to have over PPV23, putting aside these other considerations like additional vaccines. So though, maybe, I don't know, Daniel, if you have anything you'd like to add to that.
No, just to emphasize your last point. So the current product is a PPV. It's a polysaccharide vaccine, not a conjugate vaccine. So the PCV, like you just said, Sarah, has a much longer, more robust immune response that really we're trying to get, as opposed to polysaccharide vaccines. And that's part of the reason that it's being recommended, even though the PPV23 technically covers more serotypes.
Great. Thanks so much for describing that nuance. That's really helpful. And Sarah, I think you've answered this question, but I'm just going to confirm it and kind of restate it. So there was a question asking, is Pneumovax needed after the new Prevnar 20 vaccination? Based on what you've just described, I believe the answer to that would be no. Is that correct?
That's correct. That's correct.
Okay. So then the other question, I guess, that kind of, moves things along to Dan's side of the work is around coverage for Prevnar 20. We're getting a lot of questions about that. So just curious if you have any comments on that, if there's anything that you can share with regards to that.
Sure, yeah, happy to. I mean, I think as we know, the vaccines were approved relatively recently in terms of the new PCV product. So it's still going through the process in terms of approval. So in order to implement a new vaccine program, we have to make sure that we follow like a fairly significant lengthy process. We try to do it in conjunction with other provinces and territories as well, so that the whole country is moving together in lockstep on something like this. So as you can imagine, it takes quite some time. We have to make sure that we're meeting all the specific criteria. So for interest, Erickson and DeWalls is the criteria that we use to ensure that we have a good program that makes sense. So unfortunately, I can't give an update on timeline about when these might start to become publicly funded, but everything is going through the process right now, and hopefully soon we do see these products as part of our provincial program.
Great, thanks so much for providing some insight onto how that process works. That's helpful. So another question that's come up is, and this one can be answered by either of you, is can you confirm that a person who has received 2 MMR vaccines that has low antibodies, do they still need a booster? And what is the explanation for them continuing to have low antibodies after 2 vaccines?
So this question does come up from time to time, and it is outlined in the Canadian Immunization Guide that for people who have had 2 doses of measles-containing vaccine, for most people that's 2 doses of MMR, that they should be considered immune regardless of the results of serology. So there wouldn't be a need for a 3rd dose or any additional doses. And I think that you know, I'm not a medical microbiologist, so I probably won't do the best job of explaining the reason for the low antibody titers, but I think it has to do with, to some degree, some of the assays that are used for measles detection, that they're maybe not as sensitive as you know, what might actually be circulating in the immune system in terms of providing measles protection.
Great, thank you so much for that. The other question that's come up, again related to measles, is sometimes, and this is more, I guess, to the vaccine schedule, sometimes when individuals have vaccinated a 3-year-old, let's say with MMRV, and they had issues with public health and school entry because they were told that they vaccinated early, is that something that's a common practice? And do you have any advice at all for those situations?
So I saw that in the chat, and I'm actually quite surprised to see that because the requirements for school entry, and you know, this is in Daniel's shop, so I'll make sure that he agrees. I mean, it's 2 doses of measles-containing vaccine on or after the 1st birthday, and they need to be separated by 28 days. So that's the measles component. The requirements for school entry in terms of the Immunization of School Pupils Act, it's not perfectly aligned with the schedule. And in fact, I'm sure many people on this call are familiar with our measles schedule that used to be at 12 and 18 months. So I'm a bit surprised about that scenario at 3 years. I don't know if it had to do with the interval between either the past MMR, or maybe the interval between MMRV and the previous varicella dose. So that would be what I would wonder is like, is it an interval issue, and is it to do with the varicella component? But if children are receiving 2 doses of measles containing vaccine and have 2 doses of varicella containing vaccine that are appropriately spaced, so they're both live attenuated vaccines, so they need 28 days between each other or after another live virus vaccine, that should meet the requirements under the ISPA, as well as being valid doses in terms of protection. So I'm seeing Daniel nodding. I don't know, Daniel, do you want to add anything to that?
No, just nodding in agreement. Yeah, as long as the minimum intervals are met and it's after they're a year old, that's everything that should be needed for ISPA. So, sometimes it's just for whatever reason, one of the doses didn't get recorded properly, things like that would often be an issue. But having them early, as long as spaced appropriately, is not an issue.
Yeah. Great. Thanks so much for clarifying that. Hopefully that gives our colleagues some direction there. Thanks. The next question I wanted to ask, again, kind of switching gears back to pneumonia vaccination. A few people have asked questions about what should we be doing right now. So I guess, we have our patients in our office. Some of them have gotten Pneumovax. Some of them have gotten Prevnar 13. Now that we have this new one on the scene and these nasty guidelines, what counseling should we be giving?
Yeah, it's a great question, because I think that although I think Daniel gave a really nice and comprehensive answer about sort of the timelines for incorporating vaccines into publicly funded programs, when there's direct to consumer advertising on the radio and these vaccines available for purchase, it does create challenges. And I would say, just my own personal viewpoint is also, challenges in terms of equity as well, in terms of variability and the ability to privately purchase these vaccines. So, I think that for these questions, my own view is, I think if there is interest in, especially for a client who's coming forward asking, saying that they've learned about the vaccine, I think that direct to consumer advertising from some pharmacies as well, indeed. So, I hope that I've provided you with some information to respond to questions reactively if patients are asking. I think these are safe, effective vaccines. They cover a large number of serotypes, and a large, in terms of, as I said, 40 to 50% of the serotypes that we're currently seeing. But I'd certainly look to the other panelists to sort of hear their reflections on sort of what their views are about the obligations of family doctors to counsel about privately, vaccines available in the private marketplace. These are relatively new. I'm not really sure if this represents the standard of care quite yet, because it's so new. So Daniel, I don't know, do you have any perspectives on this in terms of counseling at this early stage?
Yeah, I was obviously people are coming in and asking, which again, seeing from the chat, a lot of people are getting patients coming in and asking because we know it's out there. Then you want to be able to, and Sarah just gave like an excellent overview of the data we have on this, on why these are good vaccines, and the nasty statement has even more if you feel like you need more background for it. So be sure you can counsel them effectively in that way. It's a great vaccine, and frankly, it's really a matter of time until we do see some level of coverage through a government program, realistically based on the nasty recommendations. But at this point, your patients. If you know patients that aren't going to be able to afford a product, I wouldn't be counseling that patient on something that they can't have. Obviously, that's a big concern. So it does come up to significant equity issues that Sarah discussed, and so I struggle with that a lot with these privately available vaccines. There's other ones like people mentioned Bexsero in the questions as well already, and so we do have these issues. And I think it's really incumbent to take it on a patient-by-patient basis in terms of what you think is appropriate for them, what their risk is, and what makes sense for their lifestyle.
Great, thanks so much. I'm going to take one more question from the Q&A before we move on to the next part of today's community of practice. So this question is pertaining to COVID and specifically the Arcturus variant, and if we're seeing more transmission via aerosols on conjunctiva causing conjunctivitis. And if that's the case, should eye protection be recommended when seeing all patients in clinic or when indoor spaces in general?
Yeah, I can speak to that a little bit. So from what I've seen, again, the overall risk from the new Arcturus is very low. And that's been from the WHO in terms of what the recommendations are. I haven't seen anything yet, although it is fairly early days, on specifically increased aerosol transmission, conjunctival transmission from what we've seen so far. It is relatively early days again, but that's not something I've seen in the data, and we haven't seen any signs of increased severity. Essentially just a slightly increased transmission rate compared to the previous one. So again, a kind of a slow replacement as we've seen with some of the other strains recently. But I don't know, Sarah, if you've heard anything more recently.
No, I don't have anything to add to that.
Great. And then maybe as a kind of follow-up to that, there's a question around, should we still be screening patients for COVID symptoms or exposure prior to them showing up to the office? Because that can be a very time-consuming process, very resource-intensive for administrative staff. At this point, Daniel and Sarah, given that what you've spoken about, is that something we should still be doing as a day-to-day routine practice?
Yeah, I mean, I go back to the similar comments that I said around masking in terms of specific risk for yourself, your office, your patients, your practice, that sort of thing. For this one, again, and when we get to respiratory season, it's not just COVID anymore that we're screening for with these questions, right? Like it's anything respiratory, because we know we're having that significant increase across the board. But think of what makes the most sense for your practice. Again, at this point in time, low COVID rates overall, excellent community level protection, excellent individual protection for the vast majority of people. Screening every individual is probably relatively low utility.
Great. Thanks so much. Really appreciate all the practical advice you've both given today. Thanks so much. So now we'll bring up the slide deck again, and we will turn things over to Dr. Crabtree to present on eConsult.
Thank you very much. As mentioned at the beginning, I am the family physician and the primary care lead for the Ontario E-Services program. Next slide. What is eConsult? I'm going to present today on specifically eConsult as part of a continuum of supports and services that are available to family physicians and nurse practitioners in primary care across the province. So eConsult is essentially a secure method for doctors and nurse practitioners to ask clinical questions of specialist colleagues and receive a response within a few days. It allows the clinician to support their patients in a timely and efficient way when the input of the specialist does not require a direct clinical assessment from the specialist. I graduated about 35 years ago now, and I can easily remember the days where every family doc went to the hospital in the morning and did rounds and met up with their community colleagues and had a coffee and did the old hallway consult. And so eConsult is kind of like that, but with 2023 technology, and there's payment and documentation built in on both ends. Next slide. So many of you will have access to Scope, and some of you will also be using e-referral. And the question that we get all the time is, where does Scope, e-referral, and eConsult fall? So primarily, the way to think of it is in terms of urgency and whether or not the patient needs to be seen. So Scope, for those of you who have it, is a navigation system involving a human nurse navigator for urgent cases and urgent contacts. Think of things like, I think my patient has a DVT and I need an urgent ultrasound, and it's difficult to navigate the system in your jurisdiction. So we see a lot of this in the Toronto area and in urban settings, although Scope is embedded in various regions across the province. On the other hand, e-referral is not necessarily elective, but certainly non-urgent. The patient doesn't need to be seen today or tomorrow morning at the latest. And so a referral can be sent because the patient needs to be seen by the specialist. I think there's a hernia. I think there's a something or another that needs a clinical assessment, whether that's in person or virtual, by the specialist. eConsult kind of falls in the middle and really is a clinical question. So I'm not sure what next test to order. I'm not sure whether practice guidelines would support me ordering this other test or doing this other treatment, or what is the next medication that I should be trying for this particular individual. So these are great opportunities for A, learning, but also B, just supporting your patient. And the turnaround times, the expectation on the specialist behalf is 7 days, but our median turnaround time is actually 1 day. And to be fair, that's business days. So if you submit your e-consult on a Friday at 5, you probably won't see your response till Monday, but that I think is an appropriate turnaround time when typically you would have waited weeks, months, or even years for some specialties to actually get a response with a referral. Next slide. So there are 2 types of e-consult program, and this can create some confusion, particularly where the original e-consult was deployed primarily in the Champlain region. So e-consult base was deployed back in 2009 and supports 157 managed specialties. Some of those specialties are non-physician specialties, and that's why the provincial program that is now being deployed across the province has only 120 or more than 120 different specialties. And the OTN version on the OTN hub is the provincial version, and has no cost for primary care as long as their practices are more than 50% funded by the Ministry of Health. Next slide. This is a huge slide with a lot of words on it, but these are the managed groups that we have in the provincial program, 125 of them at last count as of February. If you can identify a group of clinicians that should be on e-consult that we don't have, please let us know, because we're always looking to improve. Next slide. This slide speaks to the value of e-consult based on the responses that we receive from those clinical questionnaires that those of you who use e-consult will have experienced. In the first top left, you can see that over 90% of people indicated that e-consult confirmed a plan or gave good information for a new or additional course of action. And that e-consult supported the avoidance of a referral in just under 80% of cases. So this improves the access to referrals because it takes those individuals off the waiting lists for the specialist. On the right, you'll see that the top specialties include dermatology, but the myriad of various specialties that are utilized is very broad across the 125 groups. Next slide. So use cases for e-consult. There are 2 types of e-consult. You can actually make an e-consult with non-OHIP. So thinking of people who are out of province, people who are non-OHIP for other reasons, they may be military or RCMP. Those of you who are supporting refugees, you can use e-consult with no OHIP number. There's a checkbox to say no OHIP number not available. For public health questions about complex vaccines, we just heard about. If you get confused and those slides still don't answer your question, you can send an e-consult to public health. There's a clinical group. I've personally used the allergy and immunology group to ask for advice on vaccine, what I thought were maybe vaccine side effects, and getting information. And then our top use case up until recently has been the COVID-19 groups, where general advice on management of COVID-19 can be given without being patient specific. Now, to be fair, if you're billing for non-OHIP questions, you cannot bill the K738 because there is no OHIP number to link it to. But generally, those questions are more for educational purposes, and the billing is relatively less of a concern, I think. On the patient-specific side, we see a lot of dermatology, as mentioned previously. You can send a picture and say, are you worried? Does this need a biopsy? Which cream should I order? Does this person need to be seen in person to start a disease modifying drug, etc. Hematology is also a top user because some of the questions that can be asked don't require an in-person visit. You can send your recent labs on your patient and say, what's the next best test? Rheumatology is often another one. Some of those very strange rheumatological tests, I'm not quite sure which one to order, so I can send a clinical question. And the other ones you can do related to other learning and mentorship programs like gender affirming prescribing. If you've got someone who's wanting to start hormones and you're not quite sure how to get started, you can send that out to a trans program e-consult. Same thing with chronic pain management or advice to adjust complex medication regimens. Next slide. So what do I need to get e-consult? You need two things, really. One ID. Most of you probably have it if you're using the clinical viewer. And then you need an OTN hub account, and it's something you can sign up for on your own, and you'll get these slides, so you'll be able to click the links to access. If you need support to either get your OneID or your OTN hub, it's quite fine to reach out to the e-consult support teams across the province. They're quite happy to walk you through all the steps to get those two pieces. Once you have those two, you can actually log on to the website on the OTN hub and submit an e-consult. You don't need to do anything more. However, what we're trying to figure out and we're working toward is a fully integrated version in the EMR. And that's been part of the challenge with deploying e-consult across the province is the feedback we've received related to EMR integration and the administrative burden that we hear about for those who don't have an integration option. So if you do have an option for integration, and I'm going to speak about that in the next couple of slides, we fully support and will walk you through all the steps to get a fully integrated version if you're on one of the EMRs that support that. And then, like I said, using our change management team to be able to do that without having to do it all on your own. There are sometimes lots of onboarding steps. And again, our team is there to support you and help you understand how you can use delegates and how you can optimize your workflow so that the administrative burden of using e-consult is minimized. Then there's the question of additional work being downloaded from the specialist back to the family physician. And the big question is the advice can be received much more quickly. And in my mind, the number of calls that I would receive from a patient waiting 6 months to see a specialist is much more work to manage than sending an e-consult, which in my experience has taken less than 10 minutes, most commonly less than 5 minutes to submit, and then a couple of minutes to complete and put in my EMR. For those of you who are interested in earning credits, you can always take any of the learnings from a e-consult and turn it into a linking learning to practice education credit through Main Pro by doing the reflective exercises that would be necessary to obtain those credits. Next slide. So here are the EMRs that have integrated versions. The Ontario MD full integration is supported by 5 different EMRs. Acuro has a V1 version only at this point. And then Ocean supports the 3 most common EMRs that represent about 80% of clinicians across Ontario. And leveraging the Ocean version for those of you who have access to integration also gets you e-referral. So you would have Ocean e-referral and Ocean e-consult integration if you have one of these EMRs. Although if you have Ocean regardless, you can still use e-consult and e-referral through Ocean. Next slide. So this is just a slide about what it looks like to use the EMR to go to Ocean. For those of you who use e-referral, you click the button to make a referral, and each EMR has its own look and feel. You add your information and your attachments to the e-consult and send it via the OTN hub login to the specialist or specialty group. Usually you get a response within a couple of days. You log back into the OTN hub and you complete your reflective exercise questions or the quality improvement questions, and then upload the response back to the EMR. Next slide. So in working with e-referral and in e-consult, you can leverage delegates, but delegates have to use the non-integrated version because of the requirement for CPSO or the CNO having matching requirements for the user. So if you're using it to make an e-referral or an e-consult, then you can use the integrated version if you're, or pardon me, for e-consult. If you're not using, if you're not doing it yourself, you're asking a delegate to do it, they will have to pull separately and put it into the e-consult version. We're looking to have that changed in the future, but it is currently a privacy requirement between the OTN hub and Ocean. These are the three, as I mentioned, EMRs that are supported for the full integration. Next slide. So right now, you still have to receive an external email, and we are working with EMR vendors to allow for integration from Ocean back into the EMR, so you're not receiving those external emails. But at this point in time, many clinics actually have an administration staff, like a referral clerk or somebody managing those emails. And once you've gone into the OTN hub to respond to the clinical the questions about the case and close the case, there's now a button to allow you to send your response via HRM to your EMR. So you no longer have to PDF the documents onto your desktop and then ask your staff to upload them. You can send them to yourself automatically.
Marilyn,
so that's yes.
I'm so sorry. I think we're just actually one slide behind, like with what's being presented. So
okay.
I just want to make sure that you're aligned. Do you mind just for the team, if we can just advance one more slide?
Yep. Thank you.
Perfect. Thank you. Thanks. Sorry about.
Yep, that's perfect. Thank you. By clicking the button and sending yourself the result by HRM, it saves you those multiple clicks to PDF the document. For those of you who are subscribed to HRM, I do recognize that not everyone's subscribed to HRM for a myriad of reasons, but at least for those who do use HRM to receive reports from hospitals and other types of services, this reduces some of the administrative burden of managing an e-consult. Next slide. So this is our future vision, and I'm not going to speak to it specifically. The reason why it's not fully integrated and bi-directional is we're working on it. Rome wasn't built in a day, and we are looking at our next optimization is to allow for single sign-on. So when you link into Ocean, it will and choose an e-consult at the OTN hub, it will actually authenticate your login, and you won't have to separately log into the OTN hub as a second step. That's hopeful to come later this year or by end of fiscal, but we are dependent on various other programs and services and their resources. And so progress is slow, but we do have a future vision for a fully integrated bi-directional opportunity for e-consult and e-referral within every EMR in the province. Next slide. This is a bit of a busy slide, but it just speaks to the fact that we have deployment teams across the province. And again, once you get the slide deck, you'll be able to use the clickable links to access the support team that is in your region. Or next slide. You can certainly reach out to the general inbox for both programs, and they will redirect your request to the team that's most appropriate to support you to get onboarded. And that's all my questions, all my slides. We can take the slides down now. I should mention, I also have my colleague Andrea Huck here from the program, and I'm hopeful that she's been able to respond to some of the Q&A while I've been speaking.
Awesome. Awesome. Thanks so much. I know, Dr. Crabtree, we have limited time with you, so I'm going to ask a few questions to you directly first. So the first question I had was regarding whether you can do e-consult as a fee-for-service walk-in clinic doctor, or do you need to be in comprehensive longitudinal care?
The K738 is not limited to anybody. Anybody in Ontario who's billing or funded by OHIP can use e-consult and bill the K738 for patients, with the limitation that it has to be patient specific, so you can use their OHIP number.
Perfect. Thank you so much. And what if someone does not have an EMR?
That you can still use the web version. Absolutely. It's a little bit more of a challenge. You'd have to scan any attachments and upload them. That it's a bit clunky, but certainly it's not unavailable, for lack of a better way of putting it. And then you print the PDF version of the report and you put it back in your paper chart.
Excellent. Excellent. That's amazing. That's amazing. I wasn't sure if it would be usable without an EMR, but there you go. That's wonderful.
Absolutely.
Yeah. And in terms of another question, someone was just hoping to clarify if you could briefly go over what HRM is, just very briefly, and what you meant by that in terms of the integration.
Yeah, so Health Report Manager is what HRM stands for. It used to be Hospital Report Manager, but now it's many other organizations like big cardiology clinics and diagnostic imaging clinics that report digitally through the provincial systems to primary care mostly. For those who are in comprehensive primary care and you are the PCP for an individual, then all of the reports that are sent out by HRM will come to you automatically, and they will come digitally. So for example, I live in the Ottawa area, and when I was in full-time primary care, a patient would be discharged from the Ottawa hospital, and before they actually got back to, I'm about an hour away from Ottawa, and before my patient got back home, the discharge summary was in their chart. And it automatically populates the chart without your staff having to upload it and attach it. The disadvantage for some is if you work in multiple locations, then you end up with reports potentially in the wrong location. So it doesn't work for everybody. And I know that OMD, Ontario MD, and Dr. Chandrasena specifically, they're working on HRM optimization. But the nice thing is that the vast majority of primary care is actually using it. And it really does save that. Click the e-consult, make a PDF, upload it to my desktop, upload it to my chart, and those 47 clicks that are required. This is one button.
That's great. Thank you so much, Dr. Crabtree. I know you have to run to another meeting, so
Yes,
we'll let you go.
But I'll let Andrea take
yeah.
over and respond to the remaining questions. Thank you, everybody. I appreciate your invitation, and looking forward to working with more of you across the province to help your patients and yourselves to stop pulling out your hair waiting for a specialist. Thanks.
Thanks so much. This is such a great tool. And if I can give, a personal testimonial as well, too, like I became an e-consult user as soon as I started my practice. It was one of the things that when I joined my team, I really wanted to kind of champion within my group. And it's something that we all use on a regular basis. We even use it for teaching as well, too, since we're an academic team. And it really has helped us a lot. And as you said, in this era of, challenging access to specialists, especially, being able to have that resource and be able to get an answer 48 to 72 hours later is a game changer. And it's so helpful for your patients. And at the end of the day, too, our patients trust us the most as the family physician. So for you to be empowered by your specialist colleagues to be able to do really amazing work for them is fantastic. So I think it's a great program, and the integration piece just makes it so much easier.
Absolutely, yeah. And honestly, one of the most common use cases for me was to confirm a course of action that I had in mind and help the patient understand that that's what the specialist would have said too. So they didn't need to, my patient didn't need to drive an hour to Ottawa to find out that they should do exactly what I said they should do. So that's a wonderful tool to be able to give your patient reassurance and support, and then also support your course of action.
Mm-hmm. Absolutely. Absolutely. And then I think even, for some of those things like, dermatologist concerns where you can just take a photo and send it and get a diagnosis and get, some confirmation. I know even for me, when I'm trying to decide, do I really need to biopsy this or not? You can get that opinion right away, in 48 hours. And I think that's so helpful for your patients. And you can really then enhance your skills as a comprehensive doctor and be able to really do right by your patients in that way. So
Yep,
yeah,
for
I think,
sure.
definitely
Awesome.
some
Thank you so
practical
much, Ali
application.
and
Yeah.
team. I appreciate everything. Take
Thank
care.
you. Thanks so much for being here. Take care.
Bye-bye.
Bye. So I'm just seeing a few other questions here, so I might pose them to Andrea, and then I'm also going to ask Daniel and Sarah to also come back on as well, and then we might ask a couple questions related to vaccines and other illnesses that we didn't get to. Let me just see here in terms of our questions. So Andrea, I might just get you to restate a couple things that you typed answers to in the chat, just because I think that they're important for people to be aware of. So one thing that was asked here is whether e-consults could be done via phone, email, Zoom. Would you like to just quickly briefly go over that?
Yeah, no problem. So the e-consult platform is offered on the Ontario, on the OTN hub. So the Ontario e-consult platform is on www.otn.ca. And that can be accessed either directly through your EMR, through some of the integrations that Marilyn addressed and mentioned today, or you can go directly to the web, set up your account and submit your question that way.
Awesome, thank you. And then I did see a few questions about billing, so I just decided to take the liberty of answering that since I'm involved with the SGFP. And so that billing code, the K738 code for family physicians, is out of basket for FOs. So if you use that code, it's considered out of the basket as well. There's another way to sweeten the deal there. All right, so I'm going to turn things over back to, sorry, one more question just came in here. So Andrea, there's a question about who should I call to get set up on eConsult or onto Ocean?
So there's throughout the presentation, there were a couple of different links and intake forms. If you want to email econsultcoe@toh.ca, I can just put that in the chat. That you can get in touch with our program. We'll direct you to the right deployment team. They will do provide any support to get you onboarded, meet with you virtually or in person, depending on your location.
That's amazing. Thank you. All right, so I'm just going to pull up some of our other questions here to see if there's some additional ones that we didn't have a chance to answer. So in terms of questions related to, this is actually one that pertains more to COVID. If we know that immunity wanes for COVID vaccines after 6 months, why is there no guideline for post 6 months, but after September 1st? Is there an answer for that question from either Sarah or Daniel?
Sure, yeah, I can speak that a bit. So it's a little more complicated than just waning after 6 months as part of it. So we do see that the level of waning depends highly on age and medical comorbidities. So particularly for those who are older, who have more immunosenescence, that's when we're seeing the quicker waning with more significant decrease in level of protection, as opposed to a young, healthy individual. Again, for example, that's why children don't need any level of booster if you're young enough, partly that sort of thing. The other thing is that vaccine immunity plus natural infection, which the vast majority of the population in Ontario now has both, we see really, really robust protection out to a year and even beyond in the studies that have come out to date. So for those who are not high risk, not immunocompromised, not having other issues, realistically, most people in Ontario who have had a vaccine and infection are good for a much longer term, at least a year in terms of their overall protection, which is why we're not seeing that need to have those boosters again every 6 months in that lower risk population. I don't know if you want to add anything, Sarah.
Maybe I'll just add, I agree with everything you've said, but I think the other thing to highlight is that in terms of what we know about waning, it's also different for infection, which wanes very quickly versus, the duration of vaccine protection against severe outcomes like hospitalization and death. So that's the other thing. And that I totally agree with what Daniel has said, that vaccination plus natural infection is providing very, very long duration of protection against those severe outcomes. So just thought I would add that additional layer. It's so nuanced, but I think that's also important to highlight around hospitalizations and deaths.
Great, thanks so much for clarifying that. So this was an interesting question as well too. So there was a question pertaining to why are we boosting women for rubella if they're not immune pre-pregnancy? I'm not sure if either of you wanted to field that question. It's a little bit of a different gear, but curious if you have any thoughts on that.
Sorry, do you mind repeating the question? I caught that it was about rubella, but I'm sorry, I missed the question.
I think it's around like the rubella booster and maybe just the rationale for providing that pre-pregnancy.
Okay, sure. So I wouldn't necessarily say that there's a recommendation for necessarily a booster dose, but for people, especially for whom there is no documented immunization information, there is a recommendation for assessing the rubella immunity status of women, ideally preconception, or if you can't get it preconception, in early pregnancy. And the goal, of course, is to ensure rubella immunity, which, as everyone knows, infection during pregnancy can result in important risks to the fetus. So that is the rationale for why we're particularly concerned about rubella, and everyone would be familiar that if there isn't rubella immunity, those women or those individuals are recommended to have MMR vaccine after the baby is born. In terms of what the Canadian Immunization Guide says, after that dose, the individuals are not recommended to necessarily have ongoing repeated serology. MMR vaccine is highly immunogenic. Only one dose is needed for rubella protection. So there wouldn't be a need for ongoing monitoring of serology in future pregnancies if that one dose is documented, and also, wouldn't be a need for any ongoing regular boosters. I hope that helps clarify.
Yeah, I think so. I think that captures the spirit of that question there. So thank you both for that. I'm going to move us along to the closing slides now, so we can end off with the community of practice. So if we can pull the slide deck up again there, and I'll turn things over to Mekalai again.
Thanks, Ali. So just an update. At our last session, we had let you know that we would bring you updates once we heard more about the expression of interest process. And this is for the $18 million that will be going towards interprofessional teams in primary care. So we have received an update. What we understand is that there will be a release with more information next week, and a 5 to 6 week deadline for applications. And we've also been told that the ministry NOH will be offering a technical briefing or an information session within 1 week after that expression of interest is announced. So once we have more information at the OCFP, we will share those details with you as well.
Great. Next slide, please.
I'll just speak to this briefly. So just wanting to let you know that we have an upcoming Practicing Well session, and really looking at how to navigate difficult interactions. So that's running on May 24th, and you can register at the link that's listed. We'll send that out as well.
Great, next slide. And lastly, I want to thank all of our panelists today for being here with us. So Daniel, Sarah, Marilyn's already left, but thank you all for participating today, answering so many questions. And thank you as well to the OCFP team, the DFCM team, for all of the work that's gone into the background to ensure that today's community of practice was a success. And as well, thank you to all of our participants for your wonderful questions. We had so many today and a lot of engagement in the chat, and it's wonderful to see that. So thank you all for continuing to support the community of practice and coming out to these sessions. Our next community of practice will be on May 26, 2023, and looking forward to seeing you all there again. And if you have any questions or concerns, please feel free to contact us at any time. And like we said at the beginning of the talk, the recordings of today's session, as well as the resources, will be circulated via email, along with a survey. And please do fill that out, because it does allow us to ensure that these sessions continue to remain applicable to you, and that the content is relevant. So please make sure to fill those out. I wish you all a wonderful Friday, and have a nice weekend, and hopefully there's some nice sunshine as well. Take care.